Welcome to Variations 4, Lights and pH units. We'll be covering in this video, number 27 to 29. We're going to be talking about the basics of acidosis and alkalosis. So we'll be moving through maps 10 to 12. We'll be covering 27 to 29 all at once here. So let's dig right into it. What is the normal range of pH in the body? It says right here, 7.35 to 7.45. As you move up, we'll say that you're getting relatively basic in nature in terms of your pH. When you get to 7.55, you've got a cellular dysfunction happening. If you move all the way up to 7.8, you're dead. Okay, if we go down the acidosis way, as we move past 7.35 into lower numbers, we start saying you're relatively acidotic. If you hit 7.25, we say you've got full-blown acidosis and you've got decrease in cellular dysfunction. If we go as low as 6.8, you're dead. All right, some premises or principles here we just have to accept. We don't have the time to go into the microchemical biology of things here. So we're just going to have to accept that hydrogen is acidic, and that whenever we talk about CO2 in the respiratory system, we associate that with hydrogen, increased levels of hydrogen in the blood. In other words, if I tell you that CO2 is elevated because your patient is retaining CO2, then we have to accept the fact that what that translates to is increased amounts of circulating hydrogen in the blood, and this is acidic. Long story short, we associate increased CO2 levels with increased acidity in the body. We need to accept that as just fact right off the bat before we can move forward. On the same token, if you are lowering hydrogen, how would you do that? There's two ways to lower hydrogen. What do you think they are? Number one, if you think about what I just said, it would be blowing off excess CO2. Because if you hyperventilate, you should be getting rid of excess CO2. And because I already said, we established CO2 is synonymous with hydrogen for our level of thinking, then you're lowering hydrogen in the blood. Hydrogen is acidic. If you're lowering something that's acidic in the blood, then you're moving towards a more basic or alkalosis, alkalytic environment. Another way we can get rid of hydrogen in the body is that the kidneys can kick in and get rid of hydrogen. Finally, we just need to know that HCO3 is bicarbonate, and bicarbonate by its nature is basic. In other words, it's an alkalotic product, let's just say. It acts as a buffer. What does a buffer mean? It means that if the body, a perfectly functioning body, suddenly becomes acidotic for some reason, assuming the kidneys are working, they will produce bicarb, which is basic, and will take the body back to a more basic or alkalotic or normal environment. In other words, if we just look at this sliding scale here, if we go down to acidosis, then we can expect the body may try to produce bicarb to bring us back up to a normal range. If we become alkalotic, we might expect the body to hold on to CO2 so that it can become more acidic and bring us back to a normal range. Let's see how this plays out. Let's see some basic examples here. So let's say you have a patient under respiratory acidosis who's ventilating low. You can come up with a few reasons why a patient might be ventilating low. Brain injury, medications, hey, opioid overdose, pretty big problem these days. But there's many others. Decreased ventilation, what does that cause? Well, CO2 is going to build up. There's other problems as well, but let's just focus on this. CO2 will build up. We already said that causes an increase in hydrogen in the blood. This is acidotic. Because respiratory issues were the cause, we call it respiratory acidosis. If we do nothing, and assuming the patient lives long enough, And with an opioid overdose, that's really highly unlikely. But assuming they did live long enough, then in a day or so, the kidneys will kick in. And what are they going to do? They're going to try to get rid of hydrogen, which is acidic, increase their hydrogen excretion, or they're going to try to conserve or make bicarb, which is a basic buffer. Kidneys are great. They're hard workers, but the problem is they take time to kick in, like a day or two. And let's, someone who's overdosed on heroin doesn't have a day or two to wait for the kidneys to kick in. So what do we do? What's the circle here? What do we do when we find this patient down and, could be a heroin overdose, it could be morphine overdose on the ward because you weren't watching their RR or their LOC closely enough. We've got to restore ventilation to try to get rid of that CO2. So they might go to ICU and get intubated, or we might give Narcan on the ward. Or if we're lucky, they might naturally start to hyperventilate. I mean, who knows? I doubt it. Or we can give a bicarb IV, which acts as a buffer. Okay, let's move on. How do you get respiratory alkalosis? So we already said what happens when you hyperventilate. First of all, what could cause a patient to hyperventilate? Right, stress, anxiety, pain, some kind of psychological condition which could therefore lead to anxiety. Okay, they hyperventilate, what happens to the CO2? They're getting rid of excess CO2. That's what happens when you hyperventilate. What does that mean? They're getting rid of hydrogen, the body's becoming relatively basic or relatively alkalotic. They might end up with full-blown alkalosis. If we don't do anything and they live long enough, which they may well do, this is not as dire of a case, renal compensation, what is it going to do? Well, we're in a basic alkalotic situation, so the kidneys may excrete bicarb to try and make things less basic, or they might try to hold on to hydrogen to make things more acidic to bring us back to the middle. If we get involved earlier on, again, we may want to restore ventilation. It might be as simple as telling a patient to, hey, breathe a little slower here, take some deep breaths, slow down, or we might have to get in there and start solving pain and anxiety issues. In an extreme example, they may need to go to ICU and have their breathing controlled via machine, but I don't see that as really a viable thing. When it's hyperventilation, that's more of a hypoventilation thing. Usually if we find the cause of the hyperventilation, we can correct it right there on the ward. So we've talked about how respiratory issues, specifically hyper or hypoventilation, can cause acidosis or alkalosis. And we've talked about how we may deal with it. And we've talked about how the kidneys may deal with it if we don't. Let's move on to alkalosis. Sorry. We've talked about respiratory acidosis and respiratory alkalosis, as I just said. What I meant to say is let's move on to metabolic acidosis and metabolic alkalosis. Now, I'm going to just say right up front that we are simplifying things here. We can go a little crazy on this stuff in terms of the various metabolic causes, and you can have a patient kind of having multi-causes coming from multi-angles. We're not doing that in this unit. We're going to keep it basic. And let's talk about the basics of metabolic acidosis. First of all, you've got very unique, very nice rectangles up here. Each one is like a class, almost a class in itself, talking about how these conditions lead to metabolic acidosis. Let me make this simple. Anything that's not respiratory in origin is metabolic in origin. So if they're getting the acidosis or the alkalosis and it's not caused by hyper or hypoventilation, it's not caused by that. I'm being very clear, not caused by, because breathing will change with these patients, but the question is what caused the initial problem? So was it starvation? If it was starvation, that's metabolic. Okay. If it was a lack of sugars going to the cells, well, that's DKA, that's still metabolic. All of these here are metabolic. And let's just touch on them really, really quickly. So DKA is diabetic ketoacidosis. Basically, you're not getting sugar into the cells. You're not getting them energy. They find alternate ways to produce that energy, that produces a byproduct called ketones. You should already know this stuff. And ketones are acidic. Okay, that's going to lead to metabolic acidosis. Simple. It's a totally separate case. Shock. You start cutting off circulation or lowering circulation to key organs. Those cells get starved. They also go into what's called anaerobic metabolism. That shouldn't be news to you. That produces a byproduct called lactic acid. Guess what? Lactic acid is in the name. It's acidic. There's your acidosis. Diarrhea, you know, we see lots of patients with diarrhea. I don't know if every time they're going to end up with metabolic acidosis, but let's be fair and say it's possible that they could have alkalotic losses and that leads to acidosis. It wouldn't be my first pick of these, that's for sure. Renal disease, renal's a wild card. We already said that. Holding on to hydrogens, getting rid of bicarb, that's a possibility. And that would all lead to acidosis. All right. The good news about the respiratory system is that it kicks in fast. It'll kick in with like much quicker than a day. And you will see if you've got increased acidosis, what does the body want to do? Does it want to get rid of hydrogen or hold on to hydrogen? It wants to get rid of hydrogen. How does it get rid of hydrogen? The respiratory system. It does that by blowing off CO2. How does it do that? It has to hyperventilate. So you may find, for example, someone in DKA hyperventilating. Well, now, can you think of 2 reasons why they're hyperventilating? Number one, they're not getting the energy they need to cells. So things aren't very happy. It's kind of like someone in shock. If they're not getting the blood flow that they need, they're not getting nutrients or oxygen, that's going to cause an increase in respiratory rate in and of itself. But the main reason that's tying these all together here is that you've got an acidic environment and the body wants to get rid of excess CO2, so they're going to hyperventilate to get rid of CO2, to try to bring things back to a more alkalotic environment. Great, that kicks in really fast. The problem is, see how long you can hyperventilate for before you start to decompensate. It's very tiring to hyperventilate. So if we leave them out in the woods to hyperventilate and solve their pH issues, they're going to die. So what do we do? What's the circle here? How do we treat metabolic acidosis? Well, first of all, really important here, treat the cause. Like you've got like, so look at these causes. These aren't even all of them, but these are some major causes, especially these 3. Big time causes, big issues, common issues in medicine. Treat the cause, get in there, solve the shock issue, solve the DKA, get some insulin going on, get some fluids, get some boluses, get some dialysis. And that's kind of like what I said here. Of course, bicarb is a good thing too, because bicarb is what? It's a buffer, it's basic, bicarb buffer basic, the BBB. That's going to combat acidosis and bring us back to a normal homeostatic range. All right, final topic for this video is metabolic alkalosis. So NG suctioning or vomiting possibly could lead to alkalosis, because you think of the losing all the gastric acids. I see a lot of patients getting NG suction on the general surgery ward, and I got to say, I don't see a lot of alkalosis. I'm just putting that out there, so I don't know about the statistics on that, but it's certainly possible. Really, our bigger concern is, side note, the bigger concern is what? With vomiting, diarrhea, and NG suction, it's potassium loss, but that's a separate issue. pH is not the first issue that comes to mind, but this is textbook here, so we'll follow it. Bicarb excretion, so that's a big one. If you have some kind of kidney failure and the kidney's not excreting bicarb and you've got an increased serum bicarb, that is certainly a good way to lead to alkalosis. Okay, so treat the cause. I mean, usually this is going to be more seen with renal patients, so treatment of the cause is going to be usually dialysis. It's not the most acute problem we see, this last one here. Renal compensation. Well, that's only if you have no renal failure to begin with. If you had no renal failure to begin with, and for some reason you had increased bicarb, then the kidney would excrete it. But assuming you have renal failure, which is probably what it is, you're going to need dialysis. Anyways, respiratory rates, what's it going to do in the face of metabolic alkalosis? What's it going to do? Is it going to try to hold on to or get rid of CO2? Well, it would probably try to hold on to CO2 to try and make the environment more acidic to bring us back to a normal homeostatic range. So respiration rate would decrease, and you'd hold on. You might get slow, deep breaths, holding on to CO2. Okay, just finally before we leave this video, so the classic gold standard for kind of checking pH and looking at these things is arterial blood gases, ABGs. You can get venous blood gases too, but they're not done as often. And as I said, the gold standard is arterial blood gases, and that's usually what we're getting in the hospital. And when we get that, we're measuring pH, which is the whole question of, are we acidotic or are we alkalotic? PCO2 and bicarb, which you've talked about, and of course looking at O2 as well. We didn't talk much about O2, and we'll probably leave it out for now because the impacts of low O2 are pretty obvious to you, and they're not essential at this point for figuring out the pH status of a patient. In the next video, we'll go through some calculations to figure out the pH status of a patient, and you'll see what I mean about how we really focus on these three to figure out the pH status of a patient. We're not ignoring O2. It's extremely important. We want to figure out if our patient's hypoxemic, if they're hypoxic. This is huge. It's just not something we need to look at right now to determine pH status. If that is not clear, it will definitely be clear by the time we finish the next video.